Yeah. Thank you for Professor Trần Trí Cương, and thank you for all the college to be here at this time today. And I'm Dr. Khánh from 108 Hospital, and I'm very pleased to be here to present about this topic. And my presentation is about the series case of concurrent acute ischemic stroke and acute myocardial infarction. Let's skip some introduce about the AIS, AMI. And to go straight directly to the problem today, I want to talk that with AMI and AIS, we share some the same risk factor and cause disease. And according to some prevalence and the incidence of this happened around 0.009%. And we still have the treatment for this problem like PCI and EVT. And for each treatment, we have the different medical therapy. So when the patient have the concurrent of two severe conditions, so how can we cope with this challenging situation? And go straight to my story case. I had 3 cases from 2 years, and the first one is the male, 61 years old, and he had hypertension, regular treatment, and the symptoms is at the onset he had dry hemisphere and confused 5 hours before admitted to my hospital. The niche when he came to my hospital is 19, and we couldn't find any symptom like chest pain. It is unclear, and the condition is the stable hemodynamic. Let's see the timeline for this patient. So I start at the time when the patient came to my hospital. So 5 hours before the symptoms happened. After that, after 2 hours, this patient came to the province hospital, and at that time he was diagnosed AIS, and he was received RTPA. So, and after that he was sent to my hospital, and we did some examination, and after that we sent him to the DSA. And it is the MRI in Province Hospital. We see that the lesion, small lesion in parenchymal and frontal lobe of the left hemisphere, and the occlude of the internal carotid artery, left internal carotid artery. And the ECG at the time when he came to the Province Hospital, and to be compared with the ECG when he came to my hospital, it is different. So we can see that at the time when he came to the Province Hospital, we slightly see something happen with the V2 to V4. But when he came to my hospital, it is clearly, it is as the elevation from V2 to V4. And at that time, we think that he also had the AMI with the evidence of ECG. And after that, we have the result of cardiac biomarker is troponin T is more than 10,000 nanogram per liter, and reduced movement of the anterior wall. So it is quite clear that he has AMI at that moment. And we do the non-contrastivity again and see that the aspects still around 7. So maybe that at that time we think that he has the concurrent of AIS and AMI. And when we make the decision making, so we decided to send him to the cath lab and do both the PCI and EVT. And when we make the angio from the neurovascular, we see that the lesion from left internal carotid artery is here, and the collateral from the opposite side is very good, and at that time, we think that this one is the chronic lesion, so the prior lesion. Before, maybe it happened before before that day. And when we see that the lesion from the coronary artery, we see that the LAD have severe stenosis, and this one is. And after that, we decided to stent LAD only because we think at that time he has chronic occlude internal carotid artery. And when AMI happened, maybe heart failure or hypertension caused the symptoms of the AIS. So we just treat the coronary artery. And after the RTPA, we actually at that time we have a headache about this because how can we use antiplate? Maybe we should use the loading dose or not, because you know that the complication of intracranial hemorrhagic is very dangerous. So, but because we still have to do the PCI, so we just choose to loading aspirin and clopidogrel. After that, after 2 weeks, he was discharged to come back to the Province Hospital. But after 1 week in Province Hospital, he couldn't make it because of sepsis shock caused by pneumonia. The second patient is the male patient, 75 years old, and he has history of hypertension, regular treatment, and previous ischemic stroke with modified ranking scale is 1. And the symptom happened 6 hours before they admitted to my hospital with right hemisphere paralysis and dysphagia, no chest pain, and vital signs at that time remained stable. Niche at that time is 14. And so let's see the timeline. This timeline is different from the patient before. So around more than 20 hours before the admitted time, he had apnea and dysphagia. And after 6 hours before admitted time, he had hemiparalysis and dysphagia. So we can see that the symptoms is a little bit confused. And when we did the CTA for him, we see that the aspect is still okay, but we see that the reason. So we see the reason from the left internal carotid artery here is like sclerosis and thrombus here, but the collateral is quite well. It's quite also. And we do the ECG and cardiobiomarker, the ECG, so that we see that the QS in D2, D3, and AVF and slightly elevated of ST from D2, D3, and AVF. So according to this ECG, we can assume that maybe he had AMI before, maybe 2 days or 1 day, maybe. And the reduced in segment movement of inferior oval and cardiac biomarker troponin T is more than 6,000 nanogram per liter. And when we do the, at that time, our doctor at that shift decided to do angio in the coronary artery and neurovascular also. And when he do the angiogram in coronary artery, we see that the occlude of RCA. And at that time, he decided to stenting RCA immediately and come back to the neurovascular. we see that the lesion from the left internal carotid artery is the proximal cervical segment. So, and at that time, the doctors at that time decided to take, to treat that lesion also, and stenting the internal carotid artery also to revascular. And when we do that procedure, we put ticagrelor with loading dose and aspirin loading dose and heparin 3000 IV UI. So we can see that it is quite intensive and maybe too much for this circumstance. So after that, this patient have the complication. It is intracranial hemorrhage. It is just one day after the procedure, and the situation, the patient is deep coma, is Glasgow 3. So I think it is have many problems when the chief take the decision and take the treatment for the patient. Yeah. And the last case is the 62-year-old male with hypertension regular treatment and atrial fibrillation with no treatment. With this patient, we see that 5 hours before admitted, he had chest pain, and 1 hour before the onset of chest pain, he had hemoparalysis, and after that, he came to my hospital. And we see that the CTA, the aspect score is 8, and we see the lesion from right internal carotid artery. So we do some more examinations. So we see that with ECG, he has evidence of inferior infarction here in D2, D3, and AVF, and in echocardiogram and biomarker, we still have the evidence that this is AMI with the lesion from the inferior wall. So we do the angio from neurovascular first, and we see that it is the occlude by thrombus, and at that time we decide to aspiration by Z7 and come back to the coronary artery, and we see that the lesion from LCX is from the thrombus also, and we decided to aspiration by 3 max, the aspiration catheter from the neurovascular. So because we think that is the burden of the thrombus is too much, so we decided to take it to tackle with this lesion. We see that this one is the 3 max catheter, yeah, to take inside the LCX to take the thrombus, and it is it is the final angio. And medicine we see we use in this case is just heparin, and after that the thrombotic therapy. This patient was discharged after 1 week, and after 3 months the modified ranking scale is 2. So let's see. Let's have a glance about this problem when AMI and AIS happen at the same time. So according to some research, we see that the prevalence is about 1.6%, and they also see that it is the mortality in the group have AMI and AIS at the same time is much more worse, and it is the fatal outcome for patient. And see about the meta-analysis for this article published in 2023 with 94 patients. And we see that in this analysis, we see that the modified ranking scale at the hospital discharge is, for 0 to 2 is just 44%, and 33% was dead. And after 90 days, it is still it is very, very severe. And this analysis, we see that we compare about the intervention and medical treatment only. We see that the intervention have better outcome for patient. So let's sum up a little bit about the cause and pathology for this condition. Maybe it happened by embolic, from left ventricular thrombus or AF. And the second one is the atherosclerotic. Maybe because you know that the atherosclerotic is just the condition after many years with metabolism disease. So it can happen. And another cause, maybe hypotension. It happened after the AMI, and it affected to the brain tissues. And another cause is medical complication like aortic dissection. Sometimes it happens with type A, and hypercoagulated, especially from after COVID-19. So, and I just want to remind a little bit about sometimes, and it is the same like some presentation this morning, like AIS can cross AMI sometimes. Especially by the catecholamine, so it affects to the myocardial, so the myocardial maybe will be dead or affected, and at that time the biomarker will increase. So, but maybe the coronary is still normal, but biomarkers still increase. So sometimes it not so clear to be diagnosis for the patient. So, and to sum up, 3 cases in my series case. The case 1, we think that the chronic occlusive ICA he had before, and AMI just happened, and hypotension. So the AIS is the sequence. So for the case 2, AMI happened 1 day ago, and with the atherosclerotic. So this patient has AIS and AMI, but AMI maybe happened before. So I think for the second case, at that time, maybe we just cheat the AIS. I mean, to do the EVT to open up the internal carotid artery, and after that we will think about the coronary artery. And because before the 1 day, so the guideline for STEMI will depend on patient, not just to do it with all cost like that, and especially when at that time we use some medicines. For the case 3, it is just because of the AF, and maybe it is he is unlucky man, so AF and thrombus come to the neuro and come to the coronary artery. So let's see a little bit about the strategy in this circumstance. So for medicine, we have intravenous tissue proximity activator and antiplatelet drug. For RTPA, we have 2 kinds of guidelines for AMI and AIS. It is different. So how can we choose what dose could we choose for the patient? And especially when we have to combine with the antiplatelet drug at that time when he come to the hospital, and when we decided to do the intervention. Because when we do the intervention, we have two ways, maybe EVT or PCI. But when we do PCI, we have to use antiplatelet And you know that the contraindication of RTPA is use antiplatelet drug at that time. So, and all of that thing will be challenging because we have to decide immediately, not have much time to consulting any professor. So yeah, let's so see that at that time when case one, we do loading dose for antiplatelet, so a little bit risky. For the case 2, it had the severe complication, and the case 3 is quite okay. So the next question is PCI or EVT first. So when we decided to do the procedure, intervention procedure for patients, so what procedure will we do first, PCI or EVT? I think we will decide it depend on patient, depend on the condition of the patient, because when the patient with hemodynamic stable and no cardiac arrhythmia, so we should do the EVT first, because we know that the lesion from the brain could increase much more faster than the muscle in the heart. But on the other hand, sometimes with the patient unstable in hemodynamic and with cardiac arrhythmias, so we have to do the PCI first to stable the condition for a patient, and after that come back to the EVT. So to sum up that, I just want to tell that the simultaneous concurrent of AMI and AS is uncommon, and the concurrent of cardiac-cerebral infarction is fatal for patients, and is still a challenging condition for decision making. And we need to individualize treatment based on patient characteristic and preference. Thank you for your attention.